and if you just stand in front of the wall, and you can use the wall for balance. So I normally ask the patient just put 2 fingers on the wall, no more. And then if you stand, let's say, on the right side, just stand on one leg, and then if you go onto tiptoes, and then back down again, and you can get the patient to do it 2 to 3 times. Now what will happen is either they can't do it, or they fatigue after 2 or 3 times, or every time they do it, they won't draw in the heel stays on the outside. And it's very important to get this leg, if they keep this leg forward, what they can do is to move their centre of gravity forwards and use that to lift themselves up. So it's important to eliminate that. And that gives you an idea of whether the tib post is functioning or not. That's right, put that down. And then have a seat here. Now we stage tib post dysfunction into sort of early stages and late stages, and various names and numbers for it. But essentially the difference is that in early stages the foot and the joints are all flexible, but as time goes by, everything becomes very stiff and uncorrectable. And when I examine it, I'd like to establish what stage they are at that. So the things to do is, I should try and get you to sit this way so everyone can see. Sorry. Yeah, perfect. So what I'd like to do is get the foot. So if let's say his foot was flat, he'll be out to the side and coming out to, and the midfoot will be abducted. So what you'd like to do is to correct the valgus and bring the foot into a neutral position. And if you can do that correction without any resistance, then you know that it's a supple, correctable flat foot. Now, the other thing that you notice when you do that in a flat foot is that you find that the heel cord become very tight, because what happens is the up and down motion will be through the hind foot rather than through the Achilles tendon. So when you correct that, you find that the posterior structure becomes very tight. Now we have should we do Silver Skills? Yeah. So there's a test called the Silver Skills test. Have you come across that at all? No one's seen stuff. So basically it's a test to isolate the gastrocnemius from the soleus as a cause for the tightness. So when you correct the foot into a neutral position, with the knee straight, the gastrocnemius, which is a muscle that crosses the knee joint, becomes very tight. So you put in the gastrocnemius under tension because the knee is straight, and then you judge to see how much dorsiflexion you're gaining. It's actually better to use the lateral border of the foot to judge, because the medial border is normally quite difficult to judge because of the arch. So normally I look from the lateral side. We've got very tight, so let's just bring here. So here in the neutral position, with the knee straight, you can see I can't bring his foot up to neutral at all. So he's, if this is 90 degrees, I think he's about 10 or 15 degrees of equinus with the knee straight. So now when we bend his knee up, he goes just about to neutral. So this shows that he's got a gastrocnemius tightness, but probably a global tightness, but more so on the gastrocnemius side.
I guess with that external torsion of the tibia, that might be contributing, because the foot's out here all the time.
Yeah.
It's not really using the calf complex, which you only can use when Ali says when the talar-navicular joint's neutral. So talar-navicular joint's locked, because we can go from there to there without any ankle or Achilles motion. So there's zero Achilles motion for 30, 40 degrees equinus. It's almost neutral with zero ankle motion. And this is the chicken and egg phenomenon with flat foot. So with a chronically flat foot, you have a tight calf, or does a tight calf cause a flat foot? So if you can't get your foot up here because the calf's tight, you'll cheat like that.
Mm.
Yeah.
What was it called again? Silver?
Silver, and then Skio, SKIO.LD.
No, yeah.
Testing. Oh, it's got dots. Yeah.
Yeah.
Just testing tib post. You can isolate tib post in a young person with tib post tenosynovitis. Let's say you just want to test the power. You've got to take tib ant out of the equation. So you point the foot all the way down. Relax all these structures here. Just turn the foot in towards my hand, so to keep it pointing down as far as you can. Then turn the foot in, and using the palm to resist, fingers to feel the tendon. It all feels perfectly normal here. That's just how we test tib post. I think one other thing in the really chronically flat foot, as Ali said, he's done these screening tests, which gives it away, but just to see can you get the foot, can you invert the foot like that? That's quite a sensitive test. So a really flat foot, often you push the foot like this and it just doesn't go past neutral. And that's just a sign that they've got a very, very chronic flat foot, which is now stiff. The joints are stiff, there might be some arthritis. Tip post, so the common presentation is a middle-aged female who presents with a sudden deterioration in their foot, and their arch collapses, and you look at their foot, and perhaps both sides are flat, one side is just more abducted. That's asymmetry, and asymmetry is important. One thing to say just about the adolescent group, so if you've got an adolescent group with a stiff, flat foot, you want to get them to do a single leg heel raise, and you want to see if the heel comes in. The heel does not come in an adolescent with a flat foot. What's the diagnosis? Tarsal coalition. Yep. Tarsal coalition. The heel is attached to the calcaneus. Calcaneus is attached to the talus, or the calcaneus is attached to the navicular congenitally, with scar tissue or with bone. And that typically presents in an adolescent who's got a flat foot, who's not progressing in sport. They've managed to compensate, because young people compensate. At some point, 11, 12, 13 years old, they start presenting to you with pain. And if you examine them, they've got a stiff foot, and you give them single leg heel raise, and the heel stays out. Okay, that's a tarsal coalition. You must refer that patient to further investigations.
Any other
condition?
Conditions? Ankle impingement?
Okay, so when you sprain your ankle, really common, we've all done it. We tear our ligaments. Okay, and a lot of emphasis put on is there an ATFL tear? Is it a rupture? Is it a partial tear, complete tear? Is it a sprain? This all just gives us information about the extent of the injury. It doesn't really change our initial management. You're going to rehabilitate that patient. Okay. What causes pain after an ankle sprain? Many causes. The biggest, most common cause, 99% of the time, is impingement. And what impingement is a build-up of tissue, which is really partly the scar tissue from the ligament, but also, if you imagine the ligaments are outside here, and the inside is the lining of the joint, right? Capsule. So when you roll your ankle, you tear the ATFL, also you tear the lining of the joint too, which has all the synovial tissue. So you get a general mass of tissue which forms, which doesn't settle down, which then causes impingement. That mass can be anywhere. So the common place when someone comes to you, they'll say, I've got pain just here, they'll point just there very classically, I've got pain just there, 6 to 8 weeks post their sprain, and they're not progressing in their rehab. Clinically, you've got the fibula here. Effectively, just pop your thumb just in front of the fibula. You ask the patient to lift their foot up. Okay, that's good. Or you lift it up for them, and they say, yep, that's it, that's where my pain is. And that's anterolateral impingement. Very commonly, you'll see when someone rolls their ankle, like I've done badly in the past, this stretches out, you get a contracule crush of deltoid. Yeah? So deltoid then is also torn on their scan, let's say. And where people seem to be tender, tends to be anteromedially, interestingly. So it's just in front of the medial malleolus, anteriorly. Same test. You get your thumb there and you push up. They say, yep, that's what hurts. Anteromedial impingement. Yes, we can also get posterior impingement. And that's because when we roll our ankle, the foot's usually plantar flexed. Okay, so you get a crush effect at the back of the ankle, like a nutcracker effect. If you have an ostrigonum or a slight extension to your talus, then you've got a nutcracker there. And then you're going to get secondary inflammation. And patients will come with posterolateral, usually ankle pain, just at the back here. And the test for that, some people say hyperplantar flexion test, not very sensitive. Got to press into the back here, into the recess of the back, and then gently push down. They often say, yep, that hurts. So whatever the impingement, wherever it is, so 6 to 8 weeks, we'll inject it, okay, with steroid. And then if they don't get better after that, with more physiotherapy or therapy, then we'll escalate to an arthroscopy. I generally inject the ankle myself from the front, and if it's a posterior impingement, we'll send them for an ultrasound scan guided injection. The way just to get into the ankle, just with an injection, is very easy. You pull up with your foot, just gather around a little. Anyone do injections? So if you feel tip ant, yep, tip of the medial malleolus, and take your thumb, and you press, you get a soft spot. Okay, and that's the typical place for anteromedial impingement, and that's exactly where you go with your needle. Go bang straight in there, and you go straight into the ankle. even if they've got pain on the outside, I inject the inside personally, because it just goes everywhere. And there's less skin discoloration or depigmentation, fat on the skin if you go from this side than if you go from this side. That troubles some people. Anything else from Impinj? Any other questions on Impinj? We've got a high couch here. I just want to show you anterior draw. Haven't got anterior draw today.
We can sit on top of those chairs, can you?
I don't need to fall off.
Yeah.
I don't need to fall off. We'll just do it. Anterior draw is interesting. Who does the anterior draw on a couch? The foot extended. Yes? Who does it with a knee bent? Who doesn't do it at all? Okay, so the way I do it is that, you might do it differently.
You know,
the way I do it is knee
can.
bent with the calf relaxed. Because what we want to really be doing is pulling the calcaneus and the foot forward. So we don't want to stop that motion by having a tight gastroc, that we described earlier. Face backwards this way here. So if we look over here, what I tend to do is so the way I do it is I grab the leg with one hand. Now commonly people do this or this, which is fine. But what's quite nice to do is have control of the foot. Even with my small hands, we can grab the calcaneus and the foot, so we've got control of the foot now. And it's really important when we pull forward on the foot. What we're sort of testing, we're trying to test ATFL, right? Or CFL, or both. But when we pull, if you pull straight forward like that, generally the foot won't come forward. Do you know why? What are the ligaments on the inside?
You're jamming the talus in between malleola.
Yes, but on the inside of the ankle, yeah, there's the deltoid ligament. Deltoid ligament is a big fan-shaped ligament. It's twice as strong as the ligaments on the outside. And so if you're pulling forward, we're not just testing ATFL, we're testing the anterior fibers of deltoid too. So the way to do the anterior draw is to invert the foot slightly, because it'll always described as an anteromedial draw. So once you've relaxed deltoid, then you pull forward and back like this, and you feel a little clump there. Okay, when you pull straight forward, it's completely solid. That's where if you're doing a test, let's say with the foot planted like that, and testing ATFL like this, it can be difficult to elicit it, because deltoid's going to be under massive tension. Unless deltoid, of course, is unstable. And we're now seeing patients coming in with medial ankle instability as well as lateral. Questions on ATFL testing?
Why are you seeing more people coming in with medial instability?
I think we're picking it up more. So either combined instability, both sides. So sometimes when we're operating, we use X-ray guidance, or we use an X-ray machine. I'll invert the foot, see if the talus tilts, and I'll evert the foot. Sometimes the talus tilts into eversion as well, between deltoids and unstable. So some people are then reconstructing the deltoid. Occasionally, as we described with a very bad ankle sprain, you'll rupture deltoid or tear deltoid. Then you'll present down the road with deltoid instability. But it won't be with giving way, because we don't give way like this. We tend to give way like this because of the mechanical alignment of our limbs. So the way people present with deltoid instability is with pain. Pain and swelling just not settling, and then you look at them and they just start to flatten slightly, very subtly. And so what patients referred into us as the tib post dysfunction, where they've got a deltoid instability. Any other conditions, questions? There's loads of foot and ankle conditions. Go on.
Should we do Achilles? Achilles tendon?
Achilles? Yeah.
So with Achilles, the two issues. One is whether you're diagnosing a rupture or people who've got chronic tendinopathy and problems. So again, you started doing your screening, so you know whether there is any swelling or any problems. But when you specifically examine the Achilles, I like to get the patient kind of to stand up. I like to examine the patient prone, or if it's a chair, get them to kneel on the chair. If you turn around, just kneel on the chair like that. People just balance yourself. It's going to be a while, so get comfortable. So first of all, you're looking at the contour of the tendon. So you know you might see with a rupture, you might